Good afternoon from the Military Women's Memorial. We should be getting started in just a few minutes. We're just going to wait and see a few more attendees for signing up. Okay, I think we should go ahead and get started. My name is Donna Houle. I'm a Senior Director with the Military Women's Memorial, and we have teamed up with the HunterSeven Foundation to bring you this webinar today. As we get started, we'd like everyone to know that the webinar is being recorded, and materials will be available in the show notes following the program. This is a 60-minute webinar. The speakers will share their presentation, followed by a 20-minute Q&A. Please enter your questions in the Q&A section. The Military Women's Memorial has teamed up again with HunterSeven Foundation. They are dedicated researchers and clinicians, Chelsea Simone and Jack Ratliff. They are bringing to you most up-to-date and relevant information about health and the actions you can take today to battle and safeguard for your well-being today and into the future. Thank you for joining us today for this virtual event. It is the first in a series of 3. We will be having additional sessions on these health seminars on May 12 and on June 22nd. Additional information will be in the show notes following the program. A little bit about the Military Women's Memorial, if you're not already familiar. We honor and tell the stories of military women in all branches of the military and of all times, so past and present women serving in the military today. We are at the very entrance to Arlington National Cemetery. We have a 33,000 square foot national memorial and education center, and this is just one of the many programs that we hope to bring to the public this year. So as I would like to have the HunterSeven team introduce themselves and tell you a little bit about their research and their objectives.
Thank you so much, Donna. I appreciate it. And thank you for having us on and giving us the opportunity to take part in such an important aspect of post 9/11 veterans. My name's Chelsea. I'm a registered nurse, a master's degree in science of nursing and public health. I served in the military for 10 years as a flight medic, and I'm an ER nurse by trade. And HunterSeven was co-founded by myself and my husband in the end of 2018 to, help improve the lives of post 9/11 veterans. So, Jack.
Yeah, my name is Jack Ratliff. I am a nurse practitioner specializing in adult gerontology care, primary care specifically. And I also serve as the director of education for the HunterSeven Foundation. Enrolled in a doctorate program and really hoping to continue to contribute to the power of this work.
So the presentation, we're going to go over a few things. Today, this part of the seminar is pretty much topical. So we're going to cover down on post 9/11 demographics, the cancer climate according to DOD, self-reported qualitative data, other health-related issues such as pregnancy and infertility, cause and effect, toxins in the environment, and then a closing and a part 2 reminder, followed by a question and answer session. So a little bit about the HunterSeven Foundation. We focused it based on a public health initiative. So right now, what we're doing is we're trying to fill the gaps with clinical research. There's so many gaps in knowledge, and this is why, part of the reason why we teamed up with the Women's Memorial to do this initiative. Second, we cover down on interactive education. Education is critical to, bettering your health, improvement health. So we push for early identification and preventative screenings, understanding your exposures and risk factors. Right now, where we're at is immediate needs support. We've seen that there's a huge problem with end stage diagnoses, terminal late diagnoses, and those are really hard to reverse. And so what we're trying to do with HunterSeven is take a step back from tertiary prevention, from that late stage, and conduct early identification. Through that, we'll be able to save lives. So three different initiatives we have at the HunterSeven Foundation. Unique demographics. So females in the military, they are a unique subset, a unique population. And since the wars in Iraq, Afghanistan, the environment has changed drastically. Currently, obviously the Army is the largest branch, and there's most of our females serve within the Army. Percentage wise, that's higher in the Air Force, but we range anywhere between 7 to 21% across DoD, 7% in the Marine Corps, whereas 21% at any given time was in the Air Force. So a lot has changed in the sense that urban environments require you to adapt and overcome. So the needs of our troops overseas require women to be utilized more in combat, less of a support role and more of a combat role in terms of CSTs, FETs, the female engagement teams, the combat search teams, the cultural support teams. There are plenty different MOSs. And so in 2015, females were allowed to serve in any MOS officially. So I believe that the first Ranger graduated a few years ago. There was a female Green Beret. SEALs have had females serve alongside them for decades. So by 2013, an interesting fact came out from the DoD that said female service members had been diagnosed at a 3-to-1 ratio for cancers when compared to males. So a 3-to-1 ratio for such a small population is an extremely high number. So that's kind of where we got started with that. And so women at war, most common jobs are medical, admin, and mechanical. That's where a majority of our females serve, is in those areas. But needless to say, despite most on the outside of our tribe still believe that many females serve in those roles, but more so it's the roles that are unconventional, that we don't necessarily realize that they serve in, that places them at a higher risk. And so the women on the right here, Major Mary Jennings, she was an Air Force attack pilot, Distinguished Flying Cross, Purple Heart recipient. She was definitely one of the most intense pilots of our time. And so, her exposures are different from somebody in admin, right? And then you have, Lieutenant Colonel Tulsi Gabbard, who started off her career as an enlisted military police officer early on in the Iraq War, deployed a few times, and then took a commission. And recently, she just returned home from the Horn of Africa as an Army Civil Affairs officer. So, and then Lieutenant Commander Nikki Selby, she was one of the first females in search and rescue down in Pensacola in the 90s. So she's a Navy flight nurse. And then on the opposite side, we have Chief Shannon Kent, who unfortunately was killed in action in January in 2019, but she served as a cryptological technologist with SOCOM. And most people don't know that she was actually diagnosed with thyroid cancer that almost ended her career. She fought pretty hard in Congress to change the rules that if you were diagnosed with cancer, that it was an automatic discharge. So Shannon Kent was a thyroid cancer survivor. And then beneath her was Sergeant Tiana Barn, and she was an Army EOD technician, and she passed away January 5th, 2018 from a rare form of bile duct cancer in her early 20s. And beneath her is Major Stephanie Percellis, and she was an Air Force medical officer who passed away just, I guess it's 2 years ago. Wow, 2 years ago from soft tissue sarcoma that she fought for a while. So while many people believe that the most common jobs are mechanical and admin and medical, a lot of these women, a lot of my fellow teammates are on the front lines doing things that needed to be done to kind of adapt and overcome to what we were facing in combat. And so roots of exposures, a lot of people, the news surrounds a lot about burn pits and you name it. It's heavily related to burn pits, which is of course a problem, not to take away from burn pits, but some of the most deadly cancers aren't related to burn pit exposure. There's other routes that you can be exposed. And Inhaled, of course, affects your respiratory system, and airborne toxins from environmental pollution to munitions to small particulate matter. All of those things definitely play a role in inhalation exposures, but you got to think about ingestion too. So, a lot of our gastric cancers, a lot of our esophageal cancers, throat cancers are from ingested toxins. So everything that you breathe in also goes in through your esophagus and into your, GI system. So, toxins as a result from food overseas, arsenic, lead, airborne particles in your food, water, the stuff I remember overseas, the big pallets of water on the flight line that were just heating up, and then you go and you drink those water bottles. And of course, it might not be an issue in the beginning stage, but down the line, it might be. So things like that. And then absorption. Direct contact with the skin is one of the most unknown, serious exposures that people often overlook. So permethrin, it's a type of pesticide, and I know the Army used it. We used to take our ACUs and we'd put it in this permethrin and we'd pull it out, and then we let it dry on the flight line, and then we put it on and we wear it. And when you think about it, you just took a whole chemical compound and pretty much put it on your entire body. So things like that have led to different blood cancers, different brain cancers, neurological disorders, because that stuff seeps into your skin. And especially in a place like Iraq, where it's extremely hot, it's 120 degrees and you're on the flight line and you're running and exercising and working, and your skin pores open and the absorption rate into your skin is through the roof. So things like that are always something that we try to explain to people to look into. And absorption is a big one when we talk about the rate of cancer deaths and cancer diagnoses in medical personnel, which we'll get back to.
All right. So one of the things I'd like to highlight is in the primary care setting, if a person comes in and identifies, they say that they are a veteran, the first few things that we start to think of are PTSD. We start thinking of chronic lower back pain. We start thinking of TBI. And those are all much more obvious and easier to diagnose than some of the things that we have to deal with toxic exposure. Most military, especially those, ones deployed to Afghanistan, for example, with unexploded ordnance or shell casings. A big part of our mission in Afghanistan was identifying bomb-making facilities, and we would go in and clean those out. Whether or not we were using the right PPE and things, whether or not we even knew we were going to get into those situations at the time, we're all mission dependent. Getting exposed to chemicals, dioxins, furans, and heavy metals. Some of the examples of this would be, burning fuels, burn pits, various types of chemicals that are all dropped into these, whether it's styrofoam or plastics or just regular trash. And then we have the heavy metals. One of the things that I like to talk about when I discuss the heavy metal exposure is, just even firing our weapons, going to the firing ranges and doing indoor shoot houses and things like that. We're firing and the gas is blowing out these, various chemicals, and those chemicals are laying down on top of the surfaces. They're going into the dirt. And every time we step through those areas, we're, blowing them up into the air and inhaling them, or, even taking them, as absorption through the skin. Munitions and armor made with depleted uranium. So any of our up armored vehicles, if they remain intact, the exposure would be minimal. But any destroyed armor, which, a lot of people that went through Iraq or Afghanistan were exposed to the destroyed armor, whether it's after an IED attack, we have to, secure the perimeter, the burning and, expelling of those chemicals into the air that we're then breathing in, and we're letting it land on our bodies and into our clothing and sitting there for long periods of time. So, and then just local air pollution, if we look at the comparison between the air purity and the size of the actual particles when we're in Iraq or Afghanistan or any of the areas that we could be deployed to in the military, typically they're not first world countries. So typically we have larger particles that we're breathing in. And then, of course, we have the tuberculosis, viral and bacterial infections that we can be exposed to. These can be GI type infections. You know, a lot of us had to do key leader engagements and things like that with the local leadership. Part of that would be to accept whatever food or drink that they were giving you, and, you know, possibly be exposing yourself that way, even just through the local water. But yeah, this is just kind of a good way to look at it, is that this is not just burn pits. You know, we always get wrapped up in the idea that we have, you know, exposure to burn pits. It's easy to look at a burn pit and see how insidious and how horrifying it is. But when we look at things like this, you know, we even have jet fuels, oils, diesel, and leaded gasoline. You know, here's a guy literally lighting a pit of chemicals and garbage on fire, and, you know, exposing everyone in the area and himself to this smog, which contains all of these chemicals, which is laying on top of people, laying on top of clothing, and being inhaled, being ingested, and absorbed. We can look at the unexploded ordnance and shell casings. We kind of talked about that with the UXO as well. And then munitions, just our own munitions. You know, I can't tell you how many times I would sit in a room and just be, you know, loading up magazines for hours and hours. You'd be put on a detail and you're sticking there loading up magazines, and you're smelling that smell in your hands, you're smelling that smell in the room, and it's usually a small shack somewhere, and it's the 110-degree sunlight beaming down on you. So you're breathing more, you're sweaty, you're absorbing it into your skin, you're absorbing it onto your clothing. And a lot of people don't realize that the recommendation, whether or not you're just handling those munitions, or you know, going to an actual shoot house or a range, is you're supposed to change your clothing before you even leave those areas. So you're taking that stuff home, you're sitting in your car. Oh, sorry. Yeah, the good comment there. Yeah, forcing them to strip down and wash clothes immediately after getting home. Good call. And then we have the IED, VV-IED explosions and rocket attacks. We've kind of touched on that already a little bit too. The initial attack, we're looking at exposure to blast and pressure changes. This can cause a litany of medical problems, just immediate medical problems. But we're not, again, thinking about, you know, these burning chemicals, these fumes, these things that were sitting there around. And everyone knows that when one of our vehicles, you know, are destroyed, a lot of times we end up setting security up around it for hours and hours on end. And then again, with the sandstorms and the air quality, these are larger particles than we're used to here. So we're bringing those in. They can be either small and micro, causing little tiny micro tearing, which can lead to all kinds of lung issues as well. All right, so the cancer climate. 49% of all cancer diagnoses between 2001 and 2021 on active duty were female-specific cancers. I was genuinely shocked when I saw that number. I remember we were looking through some DoD data, and I remember specifically when I noticed this, I called Chelsea and I was kind of freaking out. I was like, okay, look, I must have done the numbers wrong. I must be looking at this wrong. I need someone else to look at this and verify that I'm not crazy. 49%. And we're talking about, we discussed earlier what small percentage that while it's still growing, females still are the minority in the military. So to have 49%, this includes male cancers. This is 49% of the total cancers diagnosed on active duty. So then we can talk about some of the more specific portions here. 46% of that 49% were actually cervical cancer. This was from the same data, so the 2001 to 2021. There could be a lot of reasons for this. Some of the exposures that we've been able to link to it, though, are like PFAS, which can be found in the drinking water, the AFF, which is it can be used in like a fire retardants, and HPV, which is the most common thing that we're going to see, especially on the civilian side. That's what you'll hear about the most. The most common age of diagnosis is between 35 and 45. One neat thing to note there too is that the average age that a woman goes through and actually seeks medical care through the VA is mid to late 40s. So they might be missing some of this prime time for screening that they would be in their most common age of diagnosis. And And then HPV is still the most common STI in the United States military. And we know that, STIs are pretty prevalent in the military in general. Breast cancer. So breast cancer diagnosis on active duty, they total up to 5,632 cases between that same period we looked at, 2001 to 2021. These numbers were quite a bit lower, but that's still a remarkably high number. We're still seeing pretty high prevalence of breast cancer in military personnel. This did include, this number was not defined between just male and females, but as we know, breast cancer is absolutely dominated by females. So some of the exposures that we can look at that we can relate to breast cancer would be benzene, BPA, flame retardants, ionizing radiation, PFAS, and pesticides. So those are things that a lot of, we come in contact pretty often. And I know that we're doing a pretty good job monitoring and dosing for ionizing radiation, but there are other sources of radiation that aren't as well organized as like looking at things in the medical field. And then of course, Chelsea talked about, even pesticides even earlier too. So breast cancer, excuse me, females who served in active duty during the post 9/11 era are 34 times more likely to be diagnosed with breast cancer than civilian females. Again, this is absolutely remarkable. We haven't been able to narrow it down to one specific thing, and that's part of what the research, that ourselves, HunterSeven is looking to try to define, but it's hard. There's so many confounding variables when you look at cancers, just cancers in general, family histories, other exposures. There's a lot of voluntary exposures that people, especially military folks tend to do, with drinking and smoking and things like that. But we look at some of these numbers in the 2010.
I can talk about these numbers also. Yeah. The backstory behind this specific, I wrote this up and did these numbers for a woman by the name of Dr. Kate Hendricks Thomas, who unfortunately passed away just a few days ago from breast cancer in her early 40s, leaving behind 2 children and a husband. She was a Marine Corps veteran, served in Iraq, and was diagnosed with breast cancer at 38 after her provider suggested, based on her occupational exposure, she goes and has a mammogram, which is not necessarily common. But as a nurse practitioner, which I take full responsibility, our nurses are doing a great job. As a nurse practitioner, her provider suggested she do this. And at the time, when the screening came back, she came back positive for stage 4 when she was asymptomatic. So this was for Dr. Kate when she asked me how common it was. And what we did is we pulled a random year in the middle of the war. So we pulled 2010 and we looked at the number of active duty females per branch, and then the number of cancer diagnoses by that year per branch. And what we did was we found the incidence ratio as compared to US Census data on the civilian diagnostic rate, age adjusted. And what we found was 34.279 times more likely if you served on active duty in 2010. It makes you 34 times more likely than a civilian female to be diagnosed with breast cancer, which is horrific. It's one of the highest rates. So whereas, 5,300 might not seem like a lot in post 9/11, when you look at the numbers like this and compare that to civilian data, it is disheartening. The median age at diagnosis for civilians is 63. And more often than not, it's not related to environmental exposures on the civilian side. It's related to the BRCA1 or BRCA2 gene. Whereas in the military, it's almost the exact opposite. There's approximately 12 to 15% of breast cancers were related to that genetic predisposition. So majority, 85%, are not. So when we did this for Dr. Kate, we sat down and we spoke with her about this, and it was eye-opening as a female in service. And you don't really think about it until you hit that age requirement, 40, 45, 50, where you need a mammogram. But these are the types of things that we want to push to our female service members, like, hey, listen, do this, understand your exposures, because that risk ratio is there. You are 34 times more likely if you served on active duty. And I know I served on active duty in 2010. So it is extremely concerning.
All right, so then here's some of the pregnancy outcomes that we look at. This was a 2014 VA study that looked at OEF and OIF veterans, 20,370 post 9/11 veterans, and found that women were 2% more likely to face infertility than men, which is even higher than the civilian population in both demographics. So with female specifically was 15.8% infertility. And then compared with males who would have 13.8%. And then with the ectopic pregnancies, this one we saw that more women who were with males who were deployed would have had 1.9%, and then females would be 1.2% for the same category. Then we look at miscarriage. Miscarriage, 18.2% for a pregnancy that was female with the exposure versus male, 13.4%. And then birth defects. These ones were pretty similar at 3.2 for male and 3.8 for female. And then we look at childhood cancer, and this is a pretty terrifying number. See, any percentage that we're able to really measure with this would be a terrifying number, but we're finding, we found that the study found that 0.7% of males who were exposed would have a child who was diagnosed with an early cancer, and then compared with 0.4% of females.
And to clarify that, it's, of course, males can't have babies. When I wrote this slide, I obviously thought that everybody knew that, except I got one text from a friend who asked me that question. So when you look at this, and I'm going to throw myself out there and talk about myself and my husband, who's also a Iraq war veteran. And what the data showed was that as a female, I'm more likely to be infertile. My husband, as a male, as he deployed to Iraq, he is actually more likely, being an Iraq war veteran, he's more likely to have a child with a woman and have an ectopic pregnancy. He's more likely to carry a genetic disposition to offer that childhood cancer. And so what's interesting is that a lot of people don't know this, is that about every 60 days, a male reproduces sperm. So every 60 days you get a fresh batch, right? Which is great. For females, every egg cell that you have day one of your birth is what you carry for the rest of your life. So certain predispositions to exposures can change how women reproduce and can change the infertility rate. So my exposures will last with me for my entire life when it comes to OB and reproduction. Whereas my husband's, his might not be as relevant because their sperm reproduces every 60 days. So that's where that came from. And just an insight on the infertility rates. These rates are not actually crazy high compared to civilian rates, but they are still significant considering.
Okay, then we look at some data from the same study. These were the exposures that were reported. So this would be from 11,573 post 9/11 veterans. Smoke, so combat related smoke, we have that 50% of those who deployed to Iraq versus almost 60% of those who deployed to Afghanistan had reported some kind of smoke related or combat smoke related. The non-ionizing radiation, these were pretty much the same with the Iraq and Afghanistan, just mid-50s. Sandstorms, which everyone who deployed knows that those are pretty frequent anyway. So those were closer to 90%, Afghanistan being slightly lower than Iraq, unsurprisingly. Diesel and gasoline exhausts, those are both sitting around 80%. Same with the fumes, organic fumes. And solvents and oils, 40% for Afghanistan and 45% for Iraq. Depleted uranium being a lot lower, and this could be due to a number of reasons, being that most people don't most people who deployed were not exposed to destroyed vehicles and things like that, which we were pretty well taught on. But there are other catalyst for exposure to depleted uranium as well. So it could be an educational deficit as well. This is, below 10% for both. Fogs and smoke screens, Iraq and Afghanistan were pretty similar with high 20s, close to 30. And then we look at the chemical, biological, and nuclear being very, very, very small numbers there. And these numbers could be a little bit higher if there was, even just better understanding for some of the catalysts there.
So I'll jump in and take this one. Last year before Memorial Day, I had a widow reach out to me and say, I hate Memorial Day because my husband served 7 combat tours with special operations, but he isn't considered a Memorial Day death because his wasn't in service in combat, his was because of cancer. And it hit me personally because, this in fact was a man who was such a great guy. And so we did this initiative where we said, hey, if you know somebody who's passed away from cancer, share their story. So we were bombarded with names and information. The mosaic can actually be seen on our website. And within a few weeks, we had over 600 names. And I pulled from a list of those names that's upwards of 1,000 now. And those names, at least 10% were female deaths. And so we looked to see what the trends were. Were there any certain trends or factors that played a role in these female stories? And 48% of the deaths that we saw were related to Army, and 8% the Marine Corps, 31% the Air Force, it makes sense as the Air Force has higher rates of females, and 13% for the Navy. And so what we looked at was the type of cancers, what were the most common cancers that caused death in these individuals, and breast cancer was number 1, followed by liver and bile duct and GI related cancers, blood cancers like leukemia, lymphoma, sarcomas, and then lung cancers. And lung cancer was very interesting. Blood cancers were very interesting because a large majority of those who passed away were officers. They were between pay grades 03 to 06, averaging between the ages of 39 to 43. The average age at death was 43 years old, which it pains me to say as a provider. And when we looked at the different military occupational specialties, this is where we bring back the whole thing about medical. Medical is one of the number 1 MOSs in post 9/11 female veterans. And so when we looked at this data, we said, okay, well, what's the common denominator? They weren't medics. The medics weren't getting sick, and the medics weren't dying. It was the higher up nursing staff, the staff that was involved with the operating rooms, the staff that was involved with surgical and you name it. And so one of the things that we found was the instruments that are cleaned, the chemical that's used to clean the instruments is a notorious blood carcinogen. It's cancer causing if it's exposed to your skin, and a big correlation between those blood and lung cancers, liver, bile duct cancers was related to that exposure of operating room and sterilization materials. So things like that are concerning. You might not be out in the field exposed to all that combat. You might be back in the combat support hospital performing, surgical, medical care and all that, but you're still exposed. And so that was one of the biggest concerns that we saw. And secondary was aviation. There was a lot of exposures in aviation. And, for those who served in the Air Force and the Navy, a good portion of the aircrafts we were surrounded by had radiation capabilities. A lot of them, for the Air Force, the fighter jets and the bombers and the attack helicopters had munitions that were specific to like the 105 rounds and the 130 rounds. Those were all made from lead, depleted uranium. And so when you're loading those rounds onto these planes, you don't think about that exposure. So what we did is, we're trying to find a way to prevent this from happening because, obviously these are fellow, service members, these are fellow veterans, and their stories matter, looking at these women and, I see breast cancer, I see brain cancer, I see sarcoma, I see lung cancer. It's devastating. And so our whole mission is to kind of find a way to identify early on and prevent these deaths from happening. So the qualitative data, while this is very topical and it's just based on the information that we have, it's not generic throughout the DoD. We're still working on that information. But, deaths are a lot harder to come by in terms of data. So, but these are things that we try to educate people to look out on and be preventative in their health. So that concludes that portion. Donna, I'm not sure if you want to jump in.
I think I'm going to herald the same message that my colleague suggested, that it's incredible information. And we are so pleased that you are bringing it to all of our constituents, and to, hopefully it will replay and replay because it's so important. I'm hoping that we share it more widely to say, everyone, like what's the last message that you wish to send out today is, even if you don't think that you should be having these tests, take action.
Right. And I mean, on the next event that you guys have scheduled, we're going to cover down on that early identification and the symptoms and survival rates and the potential and who to go to, who to talk to. And it's going to be a good one. We're excited for that. That screening guideline is going to be excellent to utilize. But I mean, if anybody has any questions, please, either raise your hand or hit it over in the chat, question and answers. We're willing to do whatever we can.
Chelsea, there are a couple of questions in the Q&A and also in the chat. So I'll start with what's in the Q&A section. There's a question asking, is the same surgical instrument cleaner still used to date? I'm not sure.
I believe so. I will find that out, but it usually is the same type of cleaner used across, whether it's civilian side, DoD side, but of course, civilian side has more regulations in terms of protective gear, but for the most part, it is still the same. It's just the lack of PPE. So, of course, being in a combat zone, you're not going to really have time to gear up. You're going to throw something in that chemical, pull it out and go from there. So.
Thanks. And the next question is, if someone is vaccinated for HPV, does that change the prevalence of risk for the individual?
It does. And that's one thing that Jack and I looked at, was you can actually see the downward trend in cervical cancer as the HPV vaccine came out. And I believe it was around 2004, 2005-ish when we really started to vaccinate, young adults. And you can actually see that curve, and it's pretty impressive, because whereas, vaccine, it is not a one answer is the main answer. Everything is different, based on your virus or, exposure risk. But that HPV vaccine did seem to really curb the trend for sure. We saw a huge drop in data.
Thanks. And then there was a question, have you looked at the Guard Reserve members who've had multiple deployments and illnesses with the same exposures?
We have. That data is actually a lot harder to find, because when the National Guard comes home from a deployment, they're on duty or on orders for a few weeks to a month, and then they are sent back into the civilian world. So there's a huge disconnect with Guard members in the VA, and there's a huge disconnect with data in terms of, your PDHAs and your deployments. And what we hypothesize is you're actually more likely to be misdiagnosed or lack of diagnosis per se if you're Guard or Reserve, because of that lack of continuum of care. There's no direct process. So, Guard and Reserve, advocate heavily for yourself, make sure you're honest on those PDHAs, make sure you're honest with your providers, talk to your civilian providers about this, because a lot of our Guard members do tend to go to civilian providers over the VA or, military hospital facilities. So there is a huge risk factor, and we do keep track of those who have passed away from cancers, but the data is unclear. We haven't been able to secure data on Guard Reserve members on illnesses downrange.
And the next question is about testing to see what toxins you may have been exposed to. I know you have some stuff on your.
What was the question?
The question was about tests that identify toxins that you were exposed to. And I know that HunterSeven has some stuff on the website that can outline some of the exposures in your exposure
Yeah.
map.
Yeah, we definitely have the exposure map. And I mean, you got to think about where you were, right? So when I talk about, being deployed to Baghdad versus being deployed to Kabul, they're two totally separate places. One's extremely hot and sandy, the other one's extremely cold and snowy, but it makes a difference. If you're up elevated in Kabul, the air pollution is terrible there because that's the way they heat the housing there. So the ozone layer is depleted, you're more likely to be exposed to radiation from the sun, UV rays, and being up elevated like that, you're more likely, to be at risk for melanoma and skin cancer. But a lot of people don't assume that because you're in a snowy area and they think that you're more likely to be exposed and have skin cancer if you're in the desert. So it really depends. You got to really assess your operational environment. So, if you were attached to a striker regiment, you got to be mindful of that up armored depleted uranium. If you were attached to an aviation regiment, you're more likely to be exposed to diesel fuels and, exhaust fumes, JP8 benzene. So, I mean, it really depends on your MOS and where you've been, but for testing purposes, I guess that's a tough one because as Jack will say, you don't want to, chase around a duck or however he says it. You don't want to just be tested for everything because of course that's not really reliable, but there's certain things you do want to be tested for, but it's based off of symptoms. So there is heavy metal testing available, but heavy metals in the same sense, they remain in your body for a certain amount of time before they get pushed out into your blood, into your lymph, and into your bone. And so if you were exposed to an amount of a heavy metal lead, for example, in a shoot house a year ago, it's not going to be as valuable of a testing level because it's already taken place in your organs and your bones. So the level's still high, but the test accuracy is going to be extremely low. So this is why you want to stay on stuff quick. You want to get on it quick as soon as that exposure happens, days, weeks, maybe a month after at latest, but you want to get on it ASAP. So it is dependent based on symptoms.
Thanks. And then the next question is, how do we use science to prove that tumor is linked to those exposures?
So this is a really good one because, like I said, a lot of the stuff surrounding the media right now is based on burn pits and presumptions. And we don't really focus so much on presumptions because healthcare, just like anything else, is individualized, right? So, for example, I have one guy right now who we're caring for who is 32 years old. He was diagnosed at 31 with pancreatic adenocarcinoma, so cancer of the pancreas at stage 1B. And so they treated him as if it was hereditary because it's very abnormal that somebody that young has that type of cancer. And so with that treatment regimen, it actually pushed his cancer to stage 4. So my job was to go back and find the reason why he got this cancer. And so this is when you got to do a deep dive of where you've been, right? He started off at Camp Pendleton. He was a MARSOC guy. Camp Pendleton, Camp Lejeune. He went to Okinawa. And so I started going through his list and I started going through all his different exposure possibilities based on his time frame. And he said to me he was on the USS Essex in the Harper's Ferry when they responded to the Fukushima nuclear incident in Japan. And right then and there, you're like, okay, this makes too much sense, right? So to prove a cancer or tumor is related, you got to take a step back and look at your overall career. And, we can also help you and provide you with ways to do that, but you got to think of the unthinkable. Where burn pits are very stimulating mentally, they get your amygdala and your fight or flight all fired up, but it's the things that you don't realize you're exposed to that are the most dangerous. So those sandstorms and like I said, it depends on the tumor type and if it's a solid tumor, blood tumor, or blood dyscrasia. It depends on the tumor. So I mean, if you have a specific type of tumor, connect with us offline and I'll be able to get that information for you, no problem.
I know we already touched on it, Chelsea, but are there any recommendations for detox heavy metal supplements?
Oof, without providing medical opinions or any of that, there are some great resources that we're going to share at the end of this. We're going to share with the Women's Memorial that you can actually go to. We're going to share books, websites, resources, and they're all ones that I've myself have personally read or Jack has read. And as you can see, we like to read. So we will share those resources. There are some great things to review and to look at that we'll definitely share, but there are protocols that you can do. But of course, you want to talk to your provider before doing anything like that.
And the last question is, if there are no symptoms after an exposure, when should you get tested or talk to a doctor about exposure risk? Maybe you can touch a little bit on how educating the provider is important for the patient.
Yeah, so myself and Jack, we're both healthcare providers. We both see a decent amount of patients daily. And so one of the big things that really hit me hard, and being a nurse, myself and Jack, we're the most trusted profession. We have been for the past 20 years, which is a huge honor. But studies show, and this was a study done at the VA, that civilian providers are approximately 4% competent to provide veteran-centric care. 4%, most trusted profession. So as a nurse, that hurts me deeply, but I see it every day in practice. When you have a young, otherwise healthy veteran, you look at somebody like Jack, he's fit, he's healthy, he looks good, but he was also a human intelligence operator in Afghanistan, exposed to a wide variety of exposures. But because he looks healthy, I wouldn't assume he was a veteran on the civilian side, because he looks he looks very business-esque, and he looks healthy. So if he came to me complaining of GI symptoms or complaining of respiratory symptoms, and he said, I'm a non-smoker, I've had this cough though for about 6 months and phlegm comes up like this, I'd be like, okay, you got the man flu, right? So this is how you got to be your own best advocate, especially in the civilian sector. Talk to your doctor, say, hey, listen, this is what I did. This is where I'm exposed. I did XYZ. I was exposed to lead on the regular. I was involved in, firefights. I was involved with, in sandstorms. I was exposed to sandstorms for 15 months straight. So things like that. And thinking about the hidden things like the molds, right? Mold is extremely toxic. I know mold in Qatar, mold in Afghanistan. There's a great woman who we're going to have on the third panel discussion, who's a sarcoma survivor, and talks about the mold in her Connex box in Iraq. And she was actually diagnosed with sarcoma in Iraq, and they think it was related to that mold. And her story is incredible. So things like that you don't expect, but it's an opportunistic infection. So, you're chronically stressed, you're tired, your diet's, down the drain, and your sleep's affected, and all these things add up, right? You're dehydrated, you're sleep deprived. And so when that chronic stress goes up, your cortisol goes up. When your cortisol goes up, your immune system tanks. And so those are all things that are opportunistic infections. So cancer, whereas you might be exposed every day to a toxin, you might not get sick, but in those opportunistic situations, it's totally different. So speak to your providers about that. And if you need help with second opinions, or if you know something's wrong, let us know. We'll coordinate it for you. We'll talk to them. It's something that we do. We care about our fellow veterans. So.
And I think we have time for one last question, specifically looking at the MOS for different branches. I know that you've seen some trends in cancers and illnesses relating to MOS. Do you want to hit on some of those top ones you've seen, or is there anywhere people can find some more information on it?
Yeah, so I see Laura's question about transportation MOSs, and what's interesting is that a study came out last year from the Department of Defense, and it showed that your exposures to small airborne particulate matter is more likely to occur outside of a base. So outside of your FOB, camp, COP, you're more likely to be exposed to high doses or high exposure rates of particulate matter outside of that base, most likely in convoys. And so what was interesting is that, not myself, but my husband's brother was a convoy commander, and he was in the second vehicle in Afghanistan, northern Afghanistan, and the particulate matter was the highest in that second vehicle, because you think about how it works, and the first vehicle's driving and it's kicking up some dust, and the second vehicle gets that brunt. And so the correlation in respiratory related conditions in those second vehicle, third vehicle individuals was higher than on base, was higher than the first lead vehicle. So Transpo is definitely an overlooked MOS. You know, their back injury rates are through the roof, but I think their respiratory rates are also extremely high, as evidenced by those studies. So MOS makes a huge difference. Special forces, we see a huge rate of cancers in special forces, and you know, they're not hanging out around burn pits. They're, you know, out kicking down doors and throwing in grenades. So big impact with those. But ironically, the highest rate of cancer compared to civilian ratios, the highest risk is in the Air Force. And whereas the Air Force deploys the least, it kind of makes you think, well, what is it? And a lot of it has to do with aviation. So MOS does make a huge difference, and we're trying to find a way to collect all that information and put it into something that is digestible.
I think that's all the questions that we have.
Why were officers at a higher risk for cancers in the Army? I wouldn't say they're at a higher risk. If I said that, I was definitely misspoken. I'm not sure where that question came from, but actually in the Army, the highest rate of cancer across male, female was lower enlisted. In the Air Force and the Navy, we see a lot of senior officers or you know, officers. In females, we see a lot of mid-grade officers because a lot of them are nurses and a lot of them are pilots. And so that's where the female part came from with officers and cancers, is a lot of nurses who were commissioned and a lot of pilots who were commissioned on the female side for cancers. So I think that's it.
Well, let us say thank you very much. It's been an incredible webinar, lots of incredible information. We do very much want to remind everyone that we do have 2 more programs coming up. And this is just the beginning, but it is on May 12th. It's a Thursday, May 12th at 2 p.m. Eastern Standard and 11 a.m. Pacific Standard. And then again on Wednesday, June 22nd, the same timing, 2 p.m. Eastern and 11 a.m. Pacific.
Thank you so much for having us.
And there will be more information in your program notes, correct?
Yeah, we're going to get everything squared away, and we're going to take a lot of this information from the questions and build out something custom. But every seminar, we're going to do a whole nother piece of this. So it'll be very specific and tailored to this, to this.
Thank you, HunterSeven, for all of your dedication and research and work on behalf of all of our military.
Thank you.